In the last few years, we have witnessed the rise of very resistant fungal species that some of them likely influenced by environmental factors and climate change. Fortunately, there has been a bit of an explosion, and it's very welcome news, in the development of new antifungals, and the pipeline has been strengthened in the last decade. We will have the ability to have new molecules, hopefully with distinct and novel mechanisms of action in the near future, and these molecules may contribute to combat these recalcitrant fungal infections that we are suffering today, particularly in the most immunocompromised patients. Today, we will discuss this very hot topic with an expert in the field who is also an editor of Antimicrobial Agents and Chemotherapy. Welcome to Editors in Conversation. The objective of this podcast is to discuss the overall threat of antifungal resistance, reflect on the antifungal pipeline in the last few years, and examine new promising antifungals. This episode is brought to you by the Antimicrobial Agents and Chemotherapy Journal, available at asm.org/AAC. I am your host, Cesar Arias, Editor-in-Chief of AAC, and this podcast is supported by the American Society for Microbiology, which publishes AAC. If you plan to publish in AAC, ASN members get up to 50% off publishing fees. So becoming a member of ASM, the largest scientific organizations in the world, is very important. Visit asm.org/membership to sign up. And don't forget to check our latest issue of AAC, available at asm.org/AAC, with outstanding papers on mechanism of resistance, pharmacology of antimicrobial agents, epidemiology, and clinical therapeutics, among others. We also have dedicated sessions of challenging clinical cases, a new section on stewardship, and reviews in new perspective on antimicrobial agents. To discuss this very important topic, I'm very honored to have Dr. Andreas Groll, who is an editor of AAC. He's professor of pediatrics and head of the infectious disease research program and deputy director of the Department of Hematology Oncology at the University Children's Hospital in Münster, Germany. He's also a pediatrician, as you may imagine. So this is actually very good because drugs don't get to children the same way that they get to adults. So Andreas, welcome to the program.
Welcome.
So let's start talking about when people talk about fungal resistance. For some reason, this series there of is becoming something that has brought the attention to the fungal resistance as something that can actually threaten human health. So, what is the current status of antifungal resistance in clinical practice?
Yes, I think what we first have to consider that we have an increasing and high global burden of invasive fungal diseases in all over the world, and in fact, over 2 million people die every year of invasive fungal infections. And as some of the lower income countries are more connecting to the scientific field, it becomes well aware that in these countries there is a huge problem with invasive fungal diseases. So the reasons for this in our daily practice, of course, are the advancements of modern medicine with more patients being immunocompromised, having indwelling devices, receiving immunosuppressed therapies. This has led to an increase in invasive fungal diseases over the past 2 to 3 decades. What we also see are influences from a changing environment. The word here is climate change. And this is something that seems to be very relevant in the emergence of Candida auris, not in its spread, but how it went from its natural habitat to colonize and infect human subjects. So we have several organisms of concerns. One is the best example probably is Candida auris currently, an emerging new yeast organism that is characterized by its uniform abilities to spread in a nosocomial setting. It can colonize the skin, it can colonize surfaces, and by that it's an ideal commensal that is transmitted in the hospital setting. And we have seen the spread of these organisms throughout the world in a few years virtually, with outbreaks first occurring and then almost having an endemic situation.
Andreas, sorry to interrupt.
Yeah.
I just wanted to make sure we emphasize this before we talk about more of the species of resistant fungi. We had a previous program, a podcast about talking about the influence of climate change with Dr. Casadeval, and the example was Candida auris. But one of the important, interesting things is these environmental factors, and these are data from the Netherlands, and you are based in Germany, about the use of pesticides and the association with resistance in molds, particularly. Can you comment on that particular issue?
Yeah. So azole resistance in Aspergillus fumigatus has been first observed at the end of or the beginning of this century in the Netherlands, and in the first report there were itraconazole was the marker. Increasing numbers of clinical isolates were itraconazole resistance, and the further workup of this problem revealed that probably the cause is the use of fungicides in agriculture, and also in the raising of the tulips, for which the Dutch people are very famous. And so the hypothesis is that azole resistance in Aspergillus fumigatus is introduced by the use of fungicides in the environment.
This is fascinating, that things that we don't think that are innocuous to the environment, we're actually selecting all these organisms. So apart from Candida auris, what other species are becoming really challenging in clinical practice?
Yeah, the second Candida species that is of concern in terms of resistance is Candida parapsilosis, azole resistance in Candida parapsilosis. It's a phenomenon that's observed in many centers and many countries. We also have Candida glabrata that is, in part inherently resistant to fluconazole or less susceptible to fluconazole, and may also pick up resistance to echinocandins. We have azole resistance in Aspergillus fumigatus, and we also have resistance in the large number of non-Aspergillus filamentous fungi. This is a large number of biologically very diverse pathogens, and I'm just citing a study from Australia where they did an analysis of around 120 cases, and there were altogether 29 different fungal species isolated in these patients. And the concerning point here is that these non-Aspergillus or rare molds have a high lethality in comparison to Aspergillus, and almost half of the patient died from their infections. And looking at the United States, there was a paper last year in CID, reporting the spread over time of the endemic dimorphic molds in the United States. And there was a nice graphical depiction of how, for example, blastomycosis and histoplasmosis that were originally found in the Mississippi and Missouri river basins can now be found in almost every county in the United States. And the same also is true for coccidioidomycosis, which is increasingly found outside its original habitat. And in addition, we have a huge problem with histoplasmosis in Middle and South America. Also in Africa, histoplasmosis is very prevalent, apart, of course, from cryptococcosis in HIV-positive individuals. And there are also endemic fungi in China and Southeast Asia, Lomentospora, for example, that's very important in these countries. And the increasing importance of fungal pathogens is also reflected in the WHO fungal priority pathogens list that came out earlier this year, and which is an indication that attention is paid to the problems of invasive fungal diseases. And this was a complicated process, the development of this list, with interactions with many involved parties, researchers, and delegates, and a complex way of negotiating then the final list that separated in organisms of critical importance, including Cryptococcus, Candida auris, Aspergillus fumigatus, and Candida albicans, probably because of its relative importance. Then there's a high priority group and a medium priority group. And of course, the prevalence of these fungal infections varies by geographical region. That's also important. So what is important in the United States or Europe in the hospital may not be important in Africa, in Central Africa, or in Southeast Asia.
Absolutely. So it is clear that this is an emerging problem, and we are facing more and more of these fungi as the world is global and we receive patients from all over the world. We are facing these challenges. So in the past, we've been able to count to sort of the main classes of antifungals, like the polyenes with the amphotericin B and liposomal, the echinocandins, and potentially the azoles that, latest generation of azoles have allowed to a more broader spectrum and all that. What is the current status of the pipeline? In the last 10 years, there are now new molecules that have been discovered, and they are moving forward quickly in clinical trials. So can you give us a perspective of how that has occurred over the years?
Yes. There was a period where experts and clinicians were thinking that nothing is happening in terms of developing new antifungal agents. We had the development of lipid formulations of amphotericin B in the late 1990s. We had the development of the echinocandins, which then resulted in the approval of the first compound, caspofungin. I think it was in 2004 or so. And then the development of new triazoles, which were also approved in the first few years of the 2000 of the first decade. And then there was a relatively long time, almost 10 years, where it was very quiet in terms of new agents. Of course, specific journals, you will always find compounds and substances, but a clinical development, there was no candidate for a clinical development. And
so what do you think that was, Andreas? Is because the pharmaceutical company were not interested, or the clinical problem was not as dramatic as it is now? What do you think that was that calm or sort of ignoring the developing of new antifungals?
Yeah, maybe the idea was that at that point we had four classes, if we include flucytosine, so at least three classes with broad spectrum antifungal activity and efficacy against invasive candidiasis. There were, over the past 2 or 3 decades, there were pivotal clinical trials in patients with candidemia, invasive candidiasis, invasive aspergillosis. And I think the belief was that these two organisms, that's the problem. But it turned out then in parallel to this that we had emergent non-aspergillus molds, and we had rare yeast organisms, we had more endemic fungi. So the whole problem of invasive fungal diseases basically developed in parallel to this, and then at a certain time point, I think it seemed of importance or also financially lucrative to look at developing new antifungal agents. And we also should not forget that the development of the echinocandins also took a long time. I mean, this didn't happen in 10 years, but it started with xylofungin, so this is then 2 more decades in the past. And also for posaconazole, there were several similar compounds that actually failed at some point because of toxicity concerns. And posaconazole is at the end of a series of progeners. And so this was also a long process. And it is, for example, for pediatrics, it is still a long process. If we look at the time periods between approval in adults and approval in children, it is, in average, it is maybe 10 years later because of the problems in recruiting patients in appropriate trials, designing trials, and problems with maybe the oral bioavailability and developing an suitable oral formulation also.
Yeah. So I just wanted to touch on this because you are a pediatrician, and the amount of immunocompromised children as in adults are increasing. And not only in the antifungal, but in general, any antimicrobials, we lack really good studies, and we need to extrapolate some of the results. How do you change that dynamics? Do you think, is there a reason why children are excluded from clinical trials, and how can we change that tide?
Yeah, I think altogether we are relatively happy in the field of antifungal therapy because today, except for one compound, isavuconazole, all of the agents approved in adults are also approved in pediatric patients, maybe not in all age groups. There is an age group, the less than 2 years old, there where some of the agents have no label. For example, voriconazole. Voriconazole is not approved in children less than 2 years of age. Posaconazole will pursue this indication, but is also not yet approved for the under 2 years old. And isavuconazole also has a waiver for the less than 1 year old. So there are some age groups that are still critical. I think this is related to the fact that invasive fungal diseases in these age groups are really rare. It's not just where malignancies occur, and the neonatal period also is not reaching into this age group. So this age group really is a problem. But other than that, we have all of the newer and older compounds available with approved dosages.
Okay,
And
great. So let's now focus on sort of new compounds. I think there is this concept. I think the first one of echinocandins with prolonged half-life.
yeah,
I guess resifungin is the leader compound on this. So can you comment on what is this compound and how would this be useful in the future?
yeah, risafungin essentially is a developed from inidula fungin. So it's based on the structure of inidula fungin, and it is an echinocandin like the other 3 approved echinocandins with the same broad but somewhat limited spectrum of activity in vitro. So it also covers Candida, Aspergillus, and also Pneumocystis. But it has a very prolonged half-life of about 130 hours, which allows for once weekly dosing in the end. And this is obviously something new and interesting for clinicians. As an oncologist who has to deal a lot with children with ALL, because this is the predominant malignancy in pediatric oncology. Some of these patients require prophylaxis, and prophylaxis is mostly azole-based, and azoles are during many phases of treatment not an option because of the concurrent use of vincristine in anti-cancer treatment. So using an echinocandin is very welcome in the setting of prophylaxis. And indeed, the clinical development also includes the development for antifungal prophylaxis. A clinical trial is currently ongoing. I'm not at the latest state of where this clinical trial is at this point in time, but it has not been completed. It has not been published. And it is very interesting because we have some information that echinocandins may be effective in prophylaxis against invasive aspergillosis also. There has been a trial in pediatric and young adults conducted by the Toronto group that essentially showed in a randomized fashion, in a randomized, open randomized clinical trial, that caspofungin in comparison to fluconazole reduces the occurrence of invasive aspergillosis in a significant way. So this is new information and novel information that did not exist before. So this trial has been published 2 or 3 years ago, but to me it's a very important trial that points to the efficacy of echinocandins also against Aspergillus. And along this line, risafungin prophylaxis has become even more interesting. Of course, there are other applications in the treatment of invasive candidiasis, and for this indication, risafungin has been approved in the United States. And just 2 weeks ago, also in the European Union for first-line treatment of candidemia and other forms of invasive candidiasis. And of course, once per week dosing offers several advantages, less access to the patient and its IV access. So this may be preventative of catheter-associated infections. Patients may be treated as an outpatient once they have stabilized, and it may just reduce the efforts of treatment in the hospital also.
So great. I mean, this is very exciting. I think. I mean, in the antibacterial world, we have these long half-life antibiotics that are being used in outpatient therapy quite significantly. So let's talk about new molecules. And I don't know who named these new molecules because they're so difficult to pronounce. But let's start with ibrexafungerp. Right? I guess it's like some French sort of thing, ibrexafungerp. So tell us about these compounds. What is the target organisms and how do you envisage this will be used?
Yeah, ibrexafungerp is a non-echinocandin glucan synthase inhibitor. So it has essentially the same target as the echinocandins, the glucan synthase complex. From a molecular structure, it's a triterpenoid, and it's structurally distinct from echinocandins. So the binding to its target, it's structurally a little bit different. There may be a lower impact of the FKS mutations that may occur in echinocandins. And this is the main mechanism of resistance for echinocandins. So an organism that may be resistant to echinocandins is not necessarily resistant to this novel class of agents. The other distinction is that ibrexafungerp is orally bioavailability. At the moment, we only have an oral formulation, an IV formulation. There seem to be problems to create an IV formulation with ibrexafungerp, and the company is pursuing congeners. Also triterpenoids that may be suitable for IV formulation. And there is a candidate. I just left Tim the other day, Trends in Medical Mycology in Athens. And there was a presentation about a candidate for the IV formulation. Very early data, but there seems to be a molecule that might be developed also for intravenous use. And the compound is currently approved for treatment in the United States for treatment of vulvovaginal candidiasis. And but it is further developed for invasive candidiasis and also refractory fungal diseases. And there are some good clinical data that support the further development of this agent. And I think another potential use could be an oral step down with an echinocandin. Echinocandins are recommended for first-line treatment of invasive candida infection, and there is the option for an oral step down to fluconazole after 1 week or so. And ibrexafungerp is a candidate for an oral step down with an in the end with an compound that targets the glucan synthase complex. So
great.
I think that's a welcome addition, and creating
that's very exciting, actually.
Yeah, some more flexibility to the glucan synthase inhibitors, oral use, and step down and different resistance profile. And this will be important in view of Candida auris, which will not disappear in the next few years.
Yeah, very good. And let's move on to the other molecule that also is difficult to pronounce, Formanojepics, right? So tell us about this molecule. What is it, and how do you envisage the use of this compound?
Yeah, the Formanojepics is a first-in-class and very potent agent. It's a selective GWT1 inhibitor, and it it inhibits the GWT1 complex and blocks the manoprotein transport into the fungal cell membrane, and this eventually leads to fungal cell death. And what is interesting on this compound is the novel mechanism of action, of course. It's broad spectrum that includes both yeasts and molds, predominantly also rare molds, with the exception of the mucorales. The tissue distribution is very good. The safety profile, there are no signals for a safety problem with this compound. It has a low propensity for drug-drug interactions, and it has been tested in IV and oral formulations. So at the moment, it had been developed by a small company. It has been taken over by Pfizer, and at the moment, the further clinical development is under review, I would say. From the perspective of a clinical mycologist, the further development would be very welcome, because it just targets some problematic fungi, rare molds, for example, Fusarium, Scedosporium, where we virtually have no compounds with activity and documented efficacy in patients. So the community of mycologists is actually waiting for the development be continued in the next few months, so that we get a signal that that there is some progress.
Those are exciting news of new compounds with new mechanism of action. And the last molecule that I want to discuss here is this compound called olorofim. So, tell us about this drug, and what is the potential future use of this drug.
Yeah, that's also a compound with a novel mechanism of action. It's a selective inhibitor of the fungal dehydroorotate dihydrogenase. And this is a key enzyme that is involved in the pyrimidine biosynthesis. Humans also have this enzyme, but there is a greater than 2,000-fold difference in the IC50 versus fungal organism. And this pyrimidine inhibition, of course, interferes with DNA and RNA synthesis and protein production, and with the synthesis of the cell wall and essential phospholipids. And this agent also has a broad spectrum of activity against the filamentous fungi and also some of the dimorphic fungi, including Coccidioides immitis, but it is also not active against mucorales, and is not active against yeast organisms. They have a different phylogenetics of the target molecule. And actually, olorofim has low MICs against Aspergillus and some of the rare molds, and it is currently in a phase 2B clinical trial in which at this point, and this is also new information just from the TIM, more than 200 patients have been enrolled. And these are patients with serious life-threatening invasive fungal diseases with no or limited treatment options. So, for example, patients with fusariosis or scedosporiosis. Approximately half of the patients have refractory invasive aspergillosis. 20% of the patients have coccidioidomycosis, which for some patients is an uncurable disease, one has to say. And the remainder of the study population has rare molds. And altogether, at this point, 150 patients have completed the main study period. And there's some discussion because altogether we have defined response criteria. So we have cure, we have partial response, we have stable disease, and in the end, deterioration or death. And a successful outcome is defined as cure and partial response. And in this cohort of very ill patients with life-threatening and chronic and difficult to treat invasive fungal infections, a successful outcome was noted in or observed in 27% of the patients. But if you add on stable disease, then the success rate would be at 75% of patients. And for some of these infections, so the community of mycologists thinks that stable disease is already a treatment success, because under different situations, these patients may have died in the interim. We have to consider that they all had no or limited other treatment options. And this is an ongoing discussion. What is also important is that there are no safety signals. About 10% of treated patients had altered liver enzymes, but this is an adverse event that seems to be dose dependent, which is kind of reassuring and manageable. So we will see how the development continues of this drug, and how the negotiations with the regulatory authorities will then proceed, in what way they will proceed.
Great. So, so very exciting, I think, very needed new tools to treat very difficult fungal infections, particularly in patients that are very immunocompromised. So when you look at the spectrum of all this, probably there is a vacuum now on the mucorales part, the zygomyces. So what are your thoughts about that vacuum? Do you think there will be something else? We definitely have now more than we had before, but how do you see that development as they become more and more frequent among the mold infections?
Yeah, I personally think that for the mucorales, amphotericin B is actually a very good drug. If you look at the MICs in vitro and also in the animal models, amphotericin products in the correct dose are very effective. And I think here it is probably most important to improve the clinical algorithms to detect these infections very early and to treat them in an appropriate fashion with amphotericin B products very early and consequent. Also, surgical interventions play an important role. There have been several analyses that have demonstrated that source control or a surgical debridement is associated with improved survival in these infections. And I think the azoles may not be at the end of their development for mucormycosis. And another option could be, for example, inhaled application of azoles, and there are also several candidates of azoles that are in development specifically for aerosolized application. So this is not just voriconazole IV solution aerosolized and administered it to a patient by some random device, but it's a targeted development of formulations that are suitable for aerosolized applications with an appropriate particle size and all the necessary preclinical background. And I think this is also promising. This is a promising development, for example, for the transplant setting, lung transplant patients where aerosolized azoles are used in clinical practice, but their application could be improved and made better over time. And otherwise, I do not see at the moment a compound with specific activity against the Mucorales. What is perhaps also an agent that is interesting is the nano carrier of amphotericin B, an oral formulation of amphotericin B. This is a called a nanocrystal amphotericin B, which is so formulated that amphotericin B is absorbed from the gastrointestinal tract. And this compound is around for almost more than 2 decades. And there has been a phase 1 clinical trial in patients with cryptococcal meningitis, and this nanocrystal amphotericin B actually performed equally well to a comparator of conventional amphotericin B plus flucytosine. So the combination with this nanocrystal amphotericin B with flucytosine and fluconazole was as good as intravenous amphotericin B. So this is interesting, and it will also be interesting how this compound will be developed for other indications. I personally do not think that cryptococcal meningoencephalitis is the ideal target disease for this compound, but there may be other applications, prophylaxis or chronic treatment of aspergillosis and difficult to treat molds. So there's actually a lot going on in the area of new antifungal agents.
So with that, and I'm gonna try to finalize our conversation. It's a very exciting conversation in terms of what is going on in the future, and I'm gonna give you the last word. So, do you think we will maintain this momentum, or do you think regulatory and financial issues may dampen this really rich pipeline in the future?
I'm actually really excited because I just come home from a conference where I was able to talk for 4 days with colleagues that are in the field, and you know how this is then after such a conference. It's full of excitement, projects, and new thoughts, new observations, new ideas. And I think that the field of invasive mycosis is really taking off. And I'm thinking, or my first thought are like countries like Africa or continents like Africa, Southeast Asia, and South America. And I also think that fungi are very versatile organisms, and climate change will have an impact on, how fungal organisms develop in the environment, how they will be able to become thermotolerant and then become pathogens in humans. So I think this field of medicine is evolving, and it's only natural that we need to see that we develop new drugs to respond to this challenge.
Well, Andreas, it's been a fantastic conversation. Thank you for staying up there in Germany and the 7 hour difference. I really appreciate this. Great conversation to think about the future, and I'm very optimistic. This is Cesar Arias, editor of AAC, editor in chief of AAC, signing off.